All right, now we're on page 5. Now this is an overview of the entire course, basically. We're going to look at, are you a good Hippie-Ronell's doctor? How would you make a good Hippie-Ronell's test? Well, one of the first things you'd want to do is present several possible cases and say, hey, what kind of history are you capable of? Tell me, would you give all of these people the same history? Now, if somebody just ran into a sign in the front of your office, I think the right question to ask is, did you hit your head? Can you remember things? Now, if somebody's coming in for a headache, I'm going to do a very careful, cautious case history. It's going to be lengthy because I know that's where the primary diagnostic information is. But if somebody's had trauma, it's a quick overview. If you've hit your head and I find out you're unconscious, I'm already calling 911. I'm already looking at vitals. I've kind of moved into just evaluating and getting you in a safe position until trauma people can come, the EMTs. So we have to assess what is the chief complaint, what's kind of going on, what does this case look like, and what's the proper history to do. So they're going to give you different scenarios, in fact 3 of them, and see if you can handle them properly. So does that make sense? I hope so. Now, what questions are important? Let's kind of look at some different scenarios. So if you have to palpate a shoulder, what kind of questions are appropriate as you're palpating a shoulder? Because part of your job is also not to just do a great history, but as you're performing your exam, do you ask the right questions of a patient when they say ow? So that you can find the target tissues. So if somebody tells you to palpate a shoulder, and somebody says, ow, what kind of questions would you ask? And if you've thought about that for a few seconds, then let's unfold the answer and take a look. I found that the right things to say pretty much are when somebody says right there, is it just there or does it radiate or refer any place? So where becomes the right question? Is there any radiation or referral pattern? Now if they tell us that it refers to their belly, all of a sudden this went from being a mechanical problem to being a visceral problem. Now I want you to take a look at that because the shoulder is very common, I guess, what's the right way to say this? It shows up in your test a lot. Okay, and the reason it does is low back and shoulder complaints can also turn visceral very quickly and very easily. So they happen to do quite a bit of shoulder and quite a bit of low back. So I want you to be wary of that in your orthoneuro stations, they'll throw in shoulders and low back a lot because they can turn it into a kidney stone or turn the shoulder into a gallbladder problem or even a lung problem. So it's very easy to do that. So mechanical versus visceral has to be in the back of your mind. Now, if Murphy's sign shows up, now that would be during your physical exam, during a belly exam. So your mind has to go to what's Murphy's sign. Remember, that's where we hook and we kind of go underneath your rib cage there and irritate the gallbladder. So if you're performing that and you're in that position and you're doing a good job and the person goes, ow, what do? Because a lot of us will jump or say, I'm sorry, or oops, or or some of you even say this word, good. When somebody heard you, good, ow, you've got to get rid of that little trigger in you, because some of you will do a straight leg raiser, somebody go, ow, you go, good, I know in school that's a good, I found it, I found the treasure, but in real life patients don't like you to say good when they hurt, so your examiner will probably take a couple of points off of you for that bad behavior. But a Murphy sign, if somebody says ow, then we've got to ask gallbladder questions. Now think for a second to yourself, and then let's take a look. This isn't a where does it hurt question, this is a when does it hurt? Does it hurt when you eat meals? Or do you have gas afterwards, postprandial? This is all a timing issue. Is it related to fatty foods, fried foods, those kind of things? So meal, gas, diet, all become really good questions, or the relationship to those. Now, when you're lifting a leg up with a straight leg raiser, and you have to know a straight leg raiser is going to show up on your test, period, end of sentence. So we'll do all the orthoneuros very carefully together, and I'll get a model here, and we'll make sure that you're doing it properly, and we'll talk about if they say ow, what's the right thing to do. We'll talk about the prep, because all of those are just little points all over that room for your test, and we want to get you a good score. But as you're lifting that leg, if the person goes, ow, you don't just hold it there. Now you let it down, and you say, gee, how far down your leg did that travel? Which leg was it? Was it both legs? Right? You're doing that kind of scenario. So where it went is really important. But a question a lot of you forget is the when question. So when you are doing a spine evaluation on somebody, it's just not where, it's when. Okay, so the where is the radiation. How far down your leg? Does it go into the top of your foot, the side of your foot, the inside of your foot, the lateral foot, the bottom of your foot? That's going to give you the nerve root. Or if it doesn't go all the way to the below the knee, then maybe it's just sciatic referral. So this is going to help us determine whether it's radiculopathy or neuropathy. The radiations is a key part of the neurological evaluation. But does it hurt when you cough, sneeze, or bear down? Tells us what structure is causing this nerve compression. So is it a disc or tumor, or is it after the IVF and somewhere out in the periphery? So we want to know if it's space occupying. Very key question. What if while you're evaluating your patient, maybe in a thoracic room, maybe it's in the physical exam room, so it could be orthoneural or physical, or even in a case history, they start coughing on you. They've been taught to cough. Then what are your cough questions? Now I want you to think for a minute. Somebody's coughing. Okay, now after that thought, did you want to know if they were coughing something up? Did you want to know if they were having a fever? And are they sweating? Are they wiping their brow when they're coughing? You know, take a look at your actor and see what they're trying to provide as information for you. I'd also want to know if they smoke. So let's take a look. I probably put those three here. I'm going to guess. Dr. Lori, don't show the next one. Okay, productive, we'd want to know the color, we want to know if they're a smoker, we want to know if there's a fever. So those are the things that would probably be top of your mind. Now the next and the last thing that I put here is lymph nodes. If you're palpating the cervical lymph nodes, now if you'll notice, this doesn't say axillary lymph nodes, this does not say inguinal lymph nodes, this says cervical lymph nodes. Okay, so they might say the lymph nodes of the neck. So you're palpating, that patient goes, ow. They even pull away. Ow, oh, that really hurts. So you don't say good. You don't say where, because it's where your fingers were. You see how silly that is? So what are lymph node questions? Now think about what these lymph nodes drain. They drain all of this, right? They drain this. So when somebody says cervical lymph nodes, you should be thinking, hey, do you have a sore throat? Do you have an earache? Have you had a runny nose? Are your eyes itchy? Do you have allergies? So let's take a look at that, Dr. Laura. So we're looking at what I call EENT, eyes, ears, nose, throat. EENT, eyes, ears, nose, throat. Okay, so we would want to ask what I call EENT questions. You know, sore throat, earache, runny nose, okay, itchy eyes. And then another great question might be, how often have you been sick? Because if somebody's been sick 7 or 8 times just in these last few months, or maybe 21 times, you know, they've had 2 kidney infections, a lung infection, they have double pneumonia, they've had, you know, and they just list a litany of things for the last 3 years, then they're not just fighting some kind of, you know, current infection, they're fighting immunodeficiency. So this is history. How good are you at portal of entry? A patient comes in, what kind of history do you do, and what kind of questions do you ask as you're performing the procedures on the patient? Are you going to be a good portal of entry doctor? Now, all right, the next place that you move, after you've done a good history, be thinking of that as she's raising the page, what is the next thing? Well, in Hippie Ronell's, the next thing you do is an exam. So when we do an exam, the symptoms that we collect from the history, oh, I cough, I sneeze, I ache, it radiates down my arm, it radiates into my foot. Those symptoms tell you what systems. Oh, it's neurological. Oh, it's gallbladder, it's abdominal. Oh, that tells you the systems, and that's going to tell you what exams to perform, what you're going to inspect, palpate, percuss, and instrumentate. So the history leads to the exams. That history, way up at the top of the page, leads to the exams. Now I want you to take a look at this next part. When you're performing exams, there's a couple of things I want you to think of, and we call them the red flags, but we've got 4 red flags here. But I want to think about your test. You've gone in and on your blank piece of paper, you've asked a person questions or done some procedures to them, you've written down some information, you have some symptoms, you've decided what exams they are. So in the hall, I want you circling all the symptoms so that you know what parts of the body are involved. So that you are picking all neuro answers, or you are picking all abdominal answers, or you're picking all reproductive answers. But if you will circle the symptoms and pick answers only in the systems that are sick, you'll get a much higher score. Even if you don't have a clue what they have, you'll probably pass the test with flying colors. Okay, now, what are the red flags? First of all, red flag. They're probably going to throw at least something approaching a 911. Now, a lot of times they put it on the x-ray day so that there's a trauma or something that's on the x-ray day. But we'll have to be able to, you know, pull out the 911, or maybe an appendicitis will show up. A trauma, we've got to be able to pull out the trauma, know, you know, when things are broken or when we have a problem. I put the female there because we've always got to be wary of a pregnancy. That's probably the number one thing that is the number one mistake we make, is that we sometimes x-ray somebody or order an x-ray and, you know, get kind of slapped on the wrist because we were wrong. Okay, and then of course age is your friend. Age is your friend. You know, somebody on an x-ray test might say that fibrous dysplasia looks a lot like Paget's, but fibrous dysplasia is under 20 and Paget's is over 50. So age is your friend. So we're going to focus on that quite a bit. All right, so we select the exams. Then the next thing we do after that is we decide if range of motion is appropriate. Now just show this much right here for a second. Range of motion has a purpose. Just like everything we've done so far, it's going to help us with the diagnosis or the case management. Now think back to page 3. If you need to look there, look there. But what's at the very bottom of the Hippie-Ronell's funnel? Why did you do history? For case history and management. Why do you do the exams? For case history and management. Why do you do the range of motion, the ortho, the neuro? For diagnosis and case management. Am I saying case history? I kept saying case history, didn't I? You do all those things for diagnosis and case management. Diagnosis and case management. So we do the history to find out the diagnosis and case management. We do the exams to find out the diagnosis and the case management. Now, I want you to look at these following situations, and I want you to ask yourself, go ahead and lower this, Dr. Laura. I want you to think, would I do range of motion? Because here's the thing, gang. Here's who's really the person you're asking. You're asking Blue Cross Blue Shield. You're asking Medicare, the government. Will you pay for the range of motion I've just taken the time to do? So it's your working diagnosis is multiple sclerosis. Would you do it or not? And you know the answer to that question is a definite maybe. You could do a yes and a no. See, and here's why. You do not need it for the diagnosis. Range of motion isn't going to help you with the diagnosis of MS. But it will give you a baseline for case management. So as you're adjusting the patient to see if there's improvement, it would be appropriate. So you can justify to Blue Cross Blue Shield that they should pay for it because you needed it for case management. So the answer is yes. You can be paid to do that. Now hopefully the rest of these get a little easier. Disc? Absolutely yes. How about hypoglycemia, range of motion? Don't you even feel silly asking Medicare for the money? Yeah, okay, so no. TOS? Yes. Bursitis? Yes. Strain, sprain? Absolutely, because active and passive are going to tell you whether you're dealing with muscle tendon or a ligament problem, so absolutely. Necessary. So this one was a definite maybe, this was an absolute no, and this was an absolute yes, and even active versus passive. So you can understand as a portal of entry provider, are you capable of distinguishing, you know, is it your case or not, and if it is your case, can you find the target tissues? That's what this is all about. Alright, then we have a few questions down here. Okay, and these questions are basically about range of motion. So just go ahead and show all of them, the rest of the page here, Dr. Laura. And I've already answered them for you, but you can cover these up in self-quiz if you want, but hopefully this makes sense. Is active or passive range of motion done by the patient? Well, they do the active part, then you push a little to do the passive, right? Now, probably some of you are saying, well, not exactly, Dr. James. What I do is I have the patient do it, and then I grab their head and I do it for them, right? Isn't that what some of you are saying? Well, on this test, first of all, here's some good news, okay? A sigh of relief. You don't have to know any numbers, ranges of motion numbers. That's what I want you to do, okay? And you don't have to use goniometers or inclinometers. Because they all vary, there's different kinds, they're expensive. That's not really what they're going for as portal of entry providers. What they want to know is if you can do active and passive range of motion, do you understand the difference, can you find the target tissues? So this is the way we'll be doing it when we get to, and we'll get our model up here and we'll do it together. But I would have the patient do active range of motion, tell me if that hurts. Okay, but what I'd have them go to the end of active, then I'd push slightly and see if there's any pain or discomfort, and then I've done active and passive. But what did the patient do? Active. What did the doctor do? Passive. Okay, so active is done by the patient, which is greater, and that would be passive, because active is here, then passive is the further range of motion. Which is done first? Active is always done first. Now, if active hurts, it doesn't mean you don't do passive. You still have to do it. Ow! Oh, that hurts? How about now? No, that didn't hurt. Okay, or ow! How about, oh, it really hurts. Okay, then both are injured. All right, so, but we still do them both. And what is the purpose of range of motion? The purpose of range of motion is to locate pain, because that helps us with the target tissues, and or difficulty, because maybe it doesn't hurt, but That's as far as I can raise it. Okay, I can't raise it any further than that tells us there's either something hampering the range of motion or that they've lost the ability to do it and the muscle is weak.